go to do the VE, we have to get our patient into the Sims position. So, Sims position, we have the patients go prone first, and then you're going to tell them, okay, go ahead and bend your leg, bend your elbow, kind of like a kickstand like we did a little bit on the UGI, right? That's so that it opens up this area so that you have access, that you can actually see what you're doing when you go to work. I was telling the other group, you're going to want to bring two types of tape. You want to bring paper tape and you want to bring plastic tape. Paper tape is for skin to skin. Plastic is going to be for like the equipment, right? So sometimes on your larger patients, you'll have to take the paper tape, put it on the inner cheek, and pull and anchor it to their ACC. So it'll pull that open so that you can actually visualize the area. Just talk to your patient as you're doing it and explain the situation, right? They're already uncomfortable, they're already embarrassed. It's just another thing in the long line of embarrassing thing that's gonna happen this day. But it's worse if you sit here and go, well, man, I think we need, I'm sorry, I need to tape your cheek over in order to see the area, something like that. Or I need to tape to the side so I can visualize the area. Just rip the Band-Aid off and say what you gotta say, okay? Only use the paper tape on the skin. You don't wanna rip it, okay? So, a couple things that we need to bring when we go to do our procedures. We have our actual bag here, and then this is going to be what?
The anal
tip or applicator, right? This one that we have right here is a biluminal. So you can see you have the straight lumen. This is where your contrast is going to come out. This guy down here, what do you think that's for?
contrast.
Yeah, no.
Oh.
Inflator. So you would inflate the balloon. Someone in the other group, not today, but someone in the other class popped my inflator, so I got to get a new one. But you would take the inflator, hook it up here, and this is how you would open the balloon. That's the balloon right there at the top, right? There is another version of it. It's called a triluminal. You have another offshoot coming off from the side. What do you think that one's for? You're not fully wrong.
Oh, it's for the double, right? Or
So it's for double contrast studies. So you have your barium that travels through here. You have your inflator here. Your third one is for air. So sometimes you want to do positive, negative studies. The positive contrast is your barium or gastrographin. The air is your negative contrast, where you're going to push air into the bowel loops. It dilates the loops, and it can also help look for leaks, like perforation somewhere, right? Okay, so we have that. You can see here, there's these lumens at the top, and then there's the actual opening there at the top in addition to it, okay? Then we have our line, then you have your bag up here. This is usually going to be a mixture. It's going to be like half water, half whatever contrast you have, right? So you might have to grab like 4 of these bottles of gastrographin, put those in here, and also put your water in here, right? I was telling the other group, so you're going to pop this guy open. If you look, it kind of adheres to it, right? You kind of have to pop it open. What you should do if you're going to mix, put the water first. Because these contrasts are like oily, or in the case of the barium, salty. They adhere, they start to gum up this area, and it's hard to fit anything in there after, and you get a little bit of reflux. So fill the water first, then put in your contrast, then close it, shake, mix, whatever, right? Some of your facilities will have pre-made jugs of Barium Enema contrast. Those typically don't get mixed with anything. They're already a suspension, so there's already water in them. I have seen a lot of techs where they'll pour that in, and then they'll mix 50% water to that, and I'm like, you've just diluted it too much. It's not going to stick to anything anymore. It's not going to adhere. So make sure you know what the prescription is, or like what the protocol is for your departments before you go and start putting stuff in, right? The other thing that we used to do, we would go take a warm blanket or a warm towel. We would wrap it around this bag and let it sit for a little while so it comes up closer to body temperature. When you go in cold, your rectum is extremely sensitive to temperature changes, and it's also very absorbent, right? So we talked about before the girls who were soaking tampons in alcohol and then putting it in their rectums because the alcohol absorbs extremely quickly through that area, right? The same thing's going to happen with what we're about to run through our patient. So those temperature changes, I think a patient care mentioned it. It's that's the problem.
I don't remember. That's crazy.
So, because those temperature changes are so drastic, you can actually put patients into cardiogenic shock. So, especially your elderly patients, You put it in, you run a bunch of very, very like ice cold contrast in there. The patient ends up vasoconstricting and they have a heart attack. Then they go into shock, patient can die on your table. Even your younger patients who that's not the concern, like their heart's strong enough to handle that, it's still really like they tighten up, they react to it, it still doesn't feel good, it still doesn't feel painful. The mucous membranes in there are also not good at protecting against really, really hot things. So it's a balance. You don't want to put something in there that's scalding hot, which can happen if you like stuck this, okay, don't do this, but I saw someone stick this on top of the warmer, and I'm like, it's plastic, it's gonna melt you more. But anyway, so don't do that. It shouldn't be scalding hot. You want it to get pretty close to body temperature, okay? So do that before you get everything together. Other supplies that we're gonna need. So, what's this called?
IV stand.
IV stand. So we need one of these guys. A couple other things. Whenever I do fluoro,
Oh my god, I got scared, sorry.
that's why I did it towards you. So, I used to grab an emesis basin every time I did any fluoro procedure. You guys have in your apartments are the big gray bucket that comes with everything, right? So you start putting all of your materials in the emesis basin, you take that over to the room. Now, when the patient goes to evac later, I have something to catch it in. It also makes it so I'm not like juggling 50 things down the hallway while I'm trying to walk over, right? So I bring my emesis basin back over here, I set it out. I don't like putting things on the tabletop, right? Because one, my patient has to move back and forth. Sometimes the doctor wants to Trendelenburg, things are gonna slide off the table, right? Everything gets sticky and wet when you're doing these procedures as well. So I usually bring a Mayo stand or a chair or something in the room, and I have my materials there, so I'm keeping my area free from work. Ms. B was saying to the other group, make sure you bring towels. Towels, sheets, washcloths, soak things up, clean things off. Even if you did this perfectly and you nailed it exactly, there's always gonna be some leakage, there's some fluid, there's something that's coming out, right? So generally speaking, bring that stuff along with you, right? It should be a given before we even do this that you took a scout KUB. Every GI study, you're gonna take some kind of scout. This one's just gonna be a scout KUB. So you're good, you're happy. I'm forgetting some things. What else should I bring? Something vitally important I need to bring. Lube.
No
I
gloves.
need lube, and I need a lot of it.
No gloves.
Gloves would be nice.
No gloves.
You go in no glove. Gloves would be smart, right? Sterile drape if you have one around the department, or like the COVID drapes, shoe covers, right? Take your watch off, stuff like that. Lube especially. No patient has ever complained about there being too much lube. It's also the cheapest thing on your tray, so take extra, right? Take extra lube. It's not just for the patient's comfort, it's for you too, because that initial push, most of your lube is gone. You're gonna use it on that initial push, and then as you're trying to move it and reposition it, you'll have nothing to help break down the friction. It's gonna be hard for you and it's gonna be uncomfortable for the patient. What I used to do is I used to grab a 4x4, which are those little gauze sponges, right? So I'd take my 4x4 and I'd put the lube on there. Instead of squirting it onto here and then like trying to get it to coat and letting gravity pull it down, you put it on the 4x4 and you twist it around inside of the loop so it coats everything evenly all the way across. Do you guys see that little bump right there?
Mm-hmm.
So generally speaking, you don't want to insert past that bump. You want to be above that bump. So I used to take the lube line down to just about there because that's how far in I could potentially have to go to do this. So I always put it there, right? So you're good, you're happy. You want a Kelly clamp as well. So you have a lock on here. These little plasticky locks are garbage. You see how it's pinching, right?
Mm-hmm.
It's so supposedly no fluid will get through there. With gravity, that fluid will get through there, right? Especially if it's like the really cheap ones, and you guys know what facilities you work at. You think they bought the good ones? No. So, I don't trust that guy. I take a Kelly clamp, which is like the hemostat, it's the non-sharp scissors. Down here, there's a hardened part where it makes a connection with the tubing. I take my Kelly and I clamp below that line. So you don't want to clamp it onto the hard part, you won't close it off. So you close off like right here and it pinches. To me, that's the best place to do it, especially because you sometimes want to pre-fill your line before you run. So if I'm going to pre-fill, I make sure I clamp down here, right? That's another happy little use for the emesis basin. Instead of having to hold this thing over a trash can and the patient's like You held that over the trash, now you're gonna insert that inside of me? Like, it's gross. You can just hold it over the MS face and when you go to fill it, right? So just be aware of all that. So you're happy, you're good, you're locked in. You hang this guy up here. That's what the holes up top are for. Some people will do the double thing where you like fold it and go both ways. I prefer not to. I usually just go one because sometimes we have to swap the bag out mid-exam, or it's not running, or this balloon pops and I have to get a new kit or something like that. So in those cases, it's much quicker to just grab it off like this. Also, when we reposition, you'll see that sometimes we have to move it around. Now, this is called a flexible applicator.
This is all like one piece. You can't just switch out the tip.
Rip the top off? You could. Once it's wet, good luck getting things to sit back on top of it. So this is a flexible applicator. I want to show you guys what we used to use. This was the rigid applicator. We'll pass it around so you can feel it. It has less lumens and it doesn't have a balloon. So you had to tape it. So when we used to tape things, this is where the plastic tape would come in. You create like a ribbon tape. So you go over the top, under the side, it creates like a tension ribbon. You don't stick it to the patient's skin, you stick it to like the drape or the clothes or something on the outside so it doesn't peel them off. I once had a student who I told him, okay, you can go ahead and ribbon, and he taped it to the table. The one thing in the room that's gonna move the whole time, right? Don't do that. So, you're good, you're happy, you took your scout, you're gonna explain to your patient, okay ma'am, we're about to get going, it's just like we talked about before, you're gonna feel a little bit of pressure, just follow my breathing instructions. So, when you go to tip, there's a maneuver to it. You're gonna go in, up and to the right. One tech that I worked with said, you're gonna aim for their belly button. So it's like you're going in and you're aiming to hit their belly button inside of them, right? When I go to do that, I'm gonna tell them, take a deep, deep, deep breath, hold it in, and out, and then you go in on out. You want them to be as relaxed as possible when you go in, because if they're still on the breathe in, they clench. They have no choice when they're trying, because if you hold the breath for a minute, when they start to relax on the breathe out, their body is naturally relaxing things. They're not gonna do that. It puts a forced relaxation, it makes it easier on that initial push. Once you get past that push, they tend to be okay, they're able to take it, right? So, I told the other group, not this. If you're comforting people, it's up here at the shoulder, right? So, okay, we're gonna go in, deep, deep breath, hold it, and breathe out, good. So we go in, and then you go up and to the right. You go just basically to that notch point. So, you're gonna go in there, you might feel that you hit pressure, you hit a wall. That means that you didn't curve enough to go into the rectosigmoid. If you hit a wall, this guy can adhere to it. That's why they end up putting these side vents on it. Because most of your contrast is going to come here from the main tip. They put these here in case you hit an obstruction or something. The problem is, it can still build a lot of pressure and it can cup this. That pressure can cause defects in the wall, you can burst the wall, stuff like that, right? It might even just slow down your flow and make the procedure take longer. So if you feel that, don't freak out. Gently pull back, reposition, and curve, right? It's not going to be perfect the first time you do it. It takes a couple of these before you're like, and you Nike swoosh it. Go in like that. You'll feel it, seriously, you'll feel when it goes in, you'll feel the catch. At a certain point, if you do it right, if you get past the curve, it like sucks it itself, like it like pulls it a little bit in.
So when you hit the wall, like on the patient, like did they feel like discomfort or like?
No, they usually don't feel that. You don't have a ton of nerve receptors in there.
Okay.
So you'll feel it.
So when you said we're living up, and sometimes once you're inside and it's like you saying there's too much friction, you just deal with it, right? You're not reapplying. You're not.
No,
right?
you pull back. If you had to completely reposition, like a tumor was sitting just to the inside, you have to come back out and go in like this instead. You could re-loop then, but typically not. No. So you go in. Okay, we're in. You curve. You're up into the area you want to be in. Don't let go. You're not ready to let go yet. The body's naturally going to say that's a foreign object, and it's going to reject it. You haven't inflated your balloon yet. So hold in place with this hand, take your other hand, you'll have a balloon inflator. It's not a bike pump. You're not trying to break it, because you'll pop the balloon, and the balloon won't pop like you're thinking, like into a million pieces. It'll get a pinhole leak. which is more sinister. It's worse because you'll think you're good, and then midway through the exam, it starts slipping out because your balloon, and you're like rapidly trying to inflate again, but no air is going in there. So it's gentle. It's usually 1, 2, 2. So then you'll feel it kind of catch a little bit. Before you let go of this, a gentle tug. Not enough to pull it out, not enough to hurt them, just a gentle tug to feel like it's firmly planted and in place. Yeah.
The book says to instruct the patient to contract their anal sphincter. Do we do that?
Good luck. Yeah.
Okay.
Quite frankly, they're gonna do it anyway.
Okay.
Like, they're gonna clench because it's uncomfortable. You could tell them, okay, if you feel it sliding, clench down. Good luck. Once this starts running and that back pressure's coming, once again, what the book says and the reality of the world, 2 different animals, right? So, gentle tug, feels good. Now you can let go. Now, usually, the balloon inflator will have its own little lock like that. You could use a Kelly for it. This one's pretty small. Those you usually do an okay job on them. But if you want to be like super cautious or you're really freaked out about it coming out, take an extra Kelly or use the Kelly that was from here because you're now going to let it run. Switch it over to this if you want. These are so thin sometimes the Kelly isn't sharp, but it can still like tear it or something, right? So you're in, we have access, cover your patient back up. So you shouldn't uncover your patient until you are ready to fire, until you're ready to start tipping, right? They're already losing enough dignity today. They're already embarrassed enough. They don't need to also be exposed to the world. Once I have the tip in, I just gently throw a towel or I pull the sheet back down a little bit. It's hard because you still need access to see what you're doing, but you don't need to be on display the whole time either. So just kind of cover them back up and you go, okay, the hard part is over. We're going to be moving you back and forth. You just do your best, okay? If it gets too uncomfortable, you tell me something, right? Call your doc, they come in the room. Usually your doc will want to take a shot just like this. So they'll take a shot, they'll look straight down into that area and go, okay, we're ready, go ahead and let's start running, right? When you go to run, as you lift, gravity increases, flow rate increases, right? It doesn't mean you always go all the way to the top point. Sometimes you don't need that much pressure, right? You find where your doctor wants. There's something called an even flow. It's like an automatic thing that you can run here that has like buttons or a pedal on it. And you push it and it'll control the flow rate. CT usually has them. It's a little more rare in X-ray because we don't get money spent on us, right? So you may have one, it has a pedal. Sometimes you give the pedal to the doctor, depending on the situation that you're in, right? So we're in, right now on this first shot, where is my contrast going to be once I run it?
In the
Rectum and starting to push into the sigmoid, right? Then your doc's gonna go, okay, let's go PA. So you're gonna slide the leg out, patient drops down, shooting right here. Now we have our first shot. Where's my contrast right now?
Sigmoid?
It's pushing out of the sigmoid and it's going into,
Descending.
is it in the descending? It's gonna go to the areas of the greatest gravitational pull. Your transverse colon sits in the front and your sigmoid rectoid also sits more toward the front. So some will pull in the sigmoid, some is gonna run straight down to the transverse and start filling the transverse. So it's almost like gonna rush right through the descending. Yeah, it should be, as long as they did all the prep beforehand. So it should run, it should get down to that transverse. So in this shot, you're looking at the transverse and you're looking at the rectosigmoid.
How much time between the first initial shot where it's in the rectum until it's in the
Totally depends on the doc. I mean, if they have good patency, like they're really open, 30 seconds, a minute.
Oh, wow.
It starts to fill really quickly because you have a lot of pressure coming. Depends on your gravity too. Pediatric, you don't need a ton of gravity.
Yeah.
They have good peristalsis, things are tight, it moves through quicker. An adult who hasn't gone to the bathroom in 2 weeks and is like on the verge of death, you take it a while to get there.
Doesn't the peristalsis only move one
Things
direction?
backwards?
Yeah.
The relative movement of
Oh,
squish
no,
and
like
squeeze and
so it's
squish and
sucking
squeeze.
up kind of?
Yeah.
Okay.
So there's like a fluid dynamic that's happening inside the body. A lot of times if we're doing this for relief, your doctor's not even paying attention. He's like, let me know if they go, right? He's on his phone or doing whatever. You're like, do you want other shots? Keep turning them until they go. If they're doing it for cancer, perforations, all of a sudden the doctor's all locked in. If you've done fluoro, you've already seen the doctors are like half out of it anyway, right? Especially on the relief BEs, because they're like, they can go to the bathroom. So, if we have situations like that, you're gonna do your shots, you'll flip your patients over, right? When you're ready to be finished, typically your doctors are gonna ask for post-evacuation shots. So they'll say, okay, go ahead and evac the patient, give it about 5 minutes, give me a lateral, give me a PA, give me an oblique, right? When you go to do that, you could pull this thing out, they'll go. That's not the best way to do this. Instead, clamp everything off, take this guy off, take the basin you brought, stick the basin on the floor, put this in the basin, and then tell the patient, I know you have the urge, it's okay, you can go ahead and go. Unclamp it. We used to put them like back in like a semi-Sims because it was a little bit easier for them to go to the bathroom. You could even put them like on their back or like this way because people are more comfortable going to the bathroom that way. The gravity will help pull everything down and now it all stays in the bag. So you don't have to clean up.
So it
as
goes
much.
through the tube?
Yep. Because they did prep beforehand. They should be mostly cleaned out, and if they had a blockage, theoretically, you broke up the blockage, it should all mix with your contrast. It should be a slurry or that comes out. You'll see the contrast. It's gonna have like a tint to it, it's like orangey brown, and it should fill in here. Sometimes there's even like a whiteness to it. You'll watch it fill the bag up. When you're done, when the bag's pretty much all the way full, you're like, okay, do you still have the sensation? No, I feel I'm pretty empty. Okay, we're gonna go ahead and remove the tube now. So, arms back up. We put them back in a Sims position. Yep.
What if it's like a yes, there's still more?
Tell them, okay, go ahead and push.
But what if the bag's full?
Keep it in the basin. That's what I'm saying, get a basin.
The basin.
Yes.
Very important.
Yes.
Yeah,
Otherwise, you're finding a commode or you're trying to grab a trash can. And, yeah. So, okay, we're done. We're good. We're gonna take it out now. We have everything we need. So, bless you. Take everything up, bring it up to this level, right? For this final pulling out or removing the tip. When you go to remove the tip, make sure you get a grip on it first. Any tape you had, undo the tape, right?
You don't undo the tape on, like for example, like you said, if we tape the cheek up, I'm not taking that off first,
No,
right?
the tape on here.
Okay.
The cheek, it has to be out of the way. That's fine. So you're here, you have a good grip. Unlock, let your air out, but you're holding it. Otherwise, the pressure is just gonna pop that thing straight out of there, right? Now, stand right here. So, what's gonna happen?
Flings out of there.
Flicks. It flicks. And sometimes you're the CI standing there and you told the student it's gonna flick and now you get flicked. So, when you go to take it out, control the tip.
They flicked again.
As it comes out, you're gonna pull and push down. So if it does flick, it flicks into the table. Smarter, put a towel over their thigh. Not just for the flick, but then you're gonna drag this, it's gonna be dripping. It goes straight into the basin, goes straight with the bag. So it comes out and you turn it down.
With
so
the on that same towel, like on that note, if we have a towel there, we can also put the lube there before we start.
Totally,
And
and
kind
then,
of,
then put it in. It'll get sticky on their thigh, but you
So
can
is
do
it-
it. It's gonna anyway.
So is it fine to have the towel just from the beginning then?
Yeah, totally.
Okay.
The problem is what we're gonna talk about in a second.
Okay.
Why maybe you might not. Because we have to go AP. So go AP, what's gonna be the problem?
you flip them over, the towel's gonna hit the board, or
I'm
it's
not
gonna
worried
fall
about
off.
the towel at the moment. What am I worried about right now?
That's.
There's a giant
Yeah,
tube
I think
sticking out of
that's-
them. When they go to turn, this is gonna wrap around their thigh. This is gonna pull out, and I can't visualize it now because they're turned over. So, I was saying before, I like to only use one hook on here because my method was, when we're gonna turn, I go, okay ma'am, we're gonna have to turn you over onto your back now, but give me just 1 second. I take this off, I bring it over, I kind of coil, and I bring it between the legs. So then when we turn, this leg flops over, this goes between the legs, and then I bring it back over again, right? It takes a little longer, and you kind of have to get the patient to go a little slower with you, right? but it's worth it. Because if it kinks around a leg or it pulls when they go to shift and it pulls out, it doesn't matter. Now it's like 10 to 15 minutes to reset everything. So I've had doctors who are like, just flip them. What are you doing? Just flip them, leave the bag. And I'm like, you're more than welcome to come out here and do it yourself, doc. This is how we're doing it. Because I'm not sitting here and starting a new bag and re-tipping my patient mid-exam, and it's always harder the second time. We've had to do it. The problem now, you've already irritated the area, and now it's in their head about they fight against it. There's already some contrast pushing back. It's much harder to tip the second time than the first. So better to just take that extra minute and a half, 2 minutes to be precautious about turning them than to do that. I've had a doctor go log roll them like we do for UGIs, like have them roll like this, and I'm like, come here then. You're gonna hold the bag over here, doc, because someone's gonna hold this bag so it doesn't catch on a foot when they go to spin, right? You are the one who's doing this procedure. You're in the room, you gotta have your big girl, big boy voice on and be like, hey, doc, I gotta do in the nicest way possible. Some doctors, no, shut up. You don't know what you're talking about, right? So do all that, take it. This goes in the red bins for like the biohazard bins. Now, back when I was still doing this, we used to have another shot called a defagram. Most of you guys will never do a defagram in your life. Good for you. That's nice. So, defagrams, we used to have to take a radiolucent toilet. You sit the patient on the radiolucent toilet and you shot decubitus from the side and you watch them defecate after the exam. Nowadays, CT's pretty much taken that away. We don't do it too much anymore. So be thankful for that. We also used to have something called a Barbie pool. I'm sure there's a proper name for it, but it was a pink inflatable pool, like a donut, little donut with a bottom. And you used to have to slide it under the patient, you turn them on, and then you untip, and they relieve themselves into the Barbie pool because the nurses had to measure the output. Because they were like, they hadn't pooped in a week and a half, and they had to make sure that so much was coming out, or whatever it was. They love to call the students. So I'd be over in ER doing like chest x-rays. Hey, we need you in fluoro right now. Oh, cool, procedure. I was excited because I'm like, arthrogram, there's a lumbar puncture. Yeah, cool, take care of the Barbie pole. And the tech keeps walking. And you're like, okay, I get it, but it's full of fluids. You're like, taking it to the toilet like this. They still exist. I haven't seen anyone use one in a long time. Again, other modalities like ultrasound have taken away some of the uses for them. But should you run into it, that's what they're talking about when they say go grab the Barbie pool, or whatever they call it. They might call it like the donut or something, right? Okay, so questions you might have to ask before and after the exam. Before the exam, allergies to contrast. Have you ever had a contrast study before? Did you do the prep? Is an extremely important question. So there's a prep for this exam. And I've had to do it before. It's called Go Lightly. I don't know if it's called Go Lightly anymore. It used to be called Go Lightly. I'm sure now it's called like sodium citrate or something like that. But basically, you aren't going to go lightly. You are going to go nonstop. It's a giant jug of a mixture of medications that relieve you of your bowel. So it's like a laxative, but it's also
It's a cathartic, right?
Cathartic, yeah. So it's a cathartic and a laxative, so it softens the stool and it pushes the stool out at the same time. And you basically had to finish that jug before you came into the procedure, and then you're usually NPO 8 to 12 hours before procedure time. So what we used to do, because some of you who work at smaller facilities or GI outpatient facilities have to do the prep on it for them. So you like prepare the jug for them. We used to put like, at 8 hours, you should have drank this far. At 12 hours, you have to be this far. At 24, you should finish the jug, something like that.
How big is it?
Bigger than you want it to be. I'll tell you right now. And they always go, oh, it tastes just like Gatorade. It doesn't taste like Gatorade. Trust me, it does not taste like Gatorade. And if it does, it's the worst Gatorade flavor you've ever had. The other horrible part is it makes you go so much, sometimes it's not worth getting off the toilet. So you're on the toilet and you're just drinking the Go Lightly on the toilet because you have to finish it. If you don't finish it, the exam can't proceed. So they're not happy, is my point. When they come in, they're not happy. They've been on the toilet all day. They're dehydrated as well. So you're gonna ask about that. Another thing you're gonna ask, have you had a recent colonoscopy? If they had a colonoscopy, we don't do the procedure. because the colonoscopy,
Would you ask them that before giving them the go lightly? Or what if they just...
a smart person would, but sometimes it's not you, sometimes it's front desk, right? Or the scheduler or something like that, and they don't see that these things are sequentially scheduled. When they do the colonoscopy, they can weaken the walls of that area so they can increase the percentage chance of perforations or irritation to the area. So, generally speaking, if they had a colonoscopy, you go, was it within the last week? If no, proceed. If yes, check with the rad first. Rad might go, they're pretty young, I'm gonna guess they're safe, but if not, or if there was a risk of perforation during the colonoscopy, we're probably not proceeding, right? Other things you're gonna ask about. Do you have a history of hemorrhoids or an active hemorrhoid right now? People know if they have a hemorrhoid, they'll tell you, right? You're gonna have to have uncomfortable conversations, get over it. When you have the hemorrhoid, it can make the job of sliding in a little more difficult. If they're so bad that they completely occlude the sphincter, we'll usually say until you get antibiotics and get looked at, we're not gonna proceed until that's fixed. I've done tons of exams where there were hemorrhoids because they're not completely blocking and we have to do the procedure. The number one population for the hemorrhoid issue is people who just gave birth. So we do a lot of these on people who just gave birth because they can create fistulas between the rectum and the front cavity. All of the pushing and bearing down they do during childbirth can cause bulging vessels in that area. So you might end up with a patient who they come straight down from postpartum. So they'll come straight down from postpartum like 2 days later to look for the fistula. And sometimes the nurses will send like preparation H with them or some kind of cream down with them. Be very careful because your natural reaction is like numbing cream. Why didn't I think of that? Like, you know, sometimes they do numbing cream before a tattoo or something. So sometimes they'll do numbing cream to help the hemorrhoids not be as painful. The problem with the numbing cream, it also like somewhat paralyzes or anesthetizes the sphincter. So it doesn't react or the patient doesn't feel things. So when it hurts, they don't tell you, right? So generally speaking, we try not to use the numbing cream if we can avoid it because it just ends up causing more problems and more damage in the long run. It also can affect the vessels at that area right there. So it's not the best thing in the world, but I have seen nurses do it before, especially on like where it's going to be massively painful to get through this exam. With the hemorrhoid, it sometimes throws off your swoosh, your Nike swoosh. So you have to like angle a little differently to get around the hemorrhoid, and then you can get up to the area that you want to work in. Okay?
And it's painful, right?
Feel
Oh yeah, no, it's
So they're gonna
painful for
move.
them, and it's harder for you. You're gonna feel it. It's a
You feel
bulge.
like in the way, so then you'll just kind of navigate. Okay.
You might have to visualize it. So I used to just ask them, especially on like older gentlemen who get them, like a lot of people who do like a lot of heavy lifting for work will get them. I used to just be like, do you have any hemorrhoids? They go, yes. I'm like, right side, left side. And they're like, right side, deep, exterior, deep. Okay. If I hit it, tell me. They're gonna tell you whether you told them that or not, but it gets them on their side a little bit. So as you're sliding, like, oh, it's right there. You're like, okay, I can fix it. I can go around it, right? Communicate with your patients, and like I said, it's uncomfortable. Guess what? Get over it. You got to talk to them. You got to get through this procedure, right? So we're gonna ask hemorrhoids. We're gonna ask the MPO. We're gonna ask if you did the prep, allergies. All of that stuff's gonna come up. When was your previous colonoscopy? I want to hear that question, and I want to hear the did you do the prep question for sure for the comp. Okay, so we definitely have to hit those ones on the comp. Post procedure, there's always going to be a chance of some leakage. If you notice blood in your stool, if you feel dizzy, lightheaded, like you're going to pass out, please go to the emergency room. Yeah.
Comp is on the dummy?
No. We're going to comp on each other.
Oh, yes.
You're not going to do all of this.
I see.
We're just going to do the positions. Yeah. We're not tipping each other. We don't got the insurance for that here. Okay, so there's always a chance of that. There's always a chance of bleeding perforation. If that occurs, please immediately go to the emergency room. You're going to be very dehydrated because of what we gave you and because you haven't eaten anything in a while. So increase your hydration for the next 24 hours, right? So that's going to be another one. Something else we do. So not every facility does this, but ours did. We had adult Pampers, like the diapers. We had them in our lungs. So I would always bring one as an option. Some people are too proud, they don't want to wear it, they're like, no, whatever, I'm not wearing diapers. Sometimes a leak after these things, because things are moving that weren't moving before. So I always offered it to them. It's just like HSGs, we offer them a pad after just in case things leak. So same here, I'd be like, I have one of these, it's totally up to you if you don't want to take it. You can also take it and decide you want to use it later. I would put it on before you put your clothes or you get into your car, just in case or anything. So that's always good. It shows them like you give a damn, you care about them, and you're going that extra mile to help them with this procedure and stuff like that, right? So I think it's good practice. I would get into the habit if it's something that your facility offers, and if it isn't, maybe it's a good conversation to have with your facility, like, hey, why don't we offer these after? Like, they're not that expensive, and it goes a long way of building patient relationships. Also, people who come for BEs tend to come for other GI studies, and then they're like, hey, you're that guy who helped make sure my car didn't get stained or whatever. Good looking out, it did leak, something like that, right? So you're gonna talk about that. You're gonna check to see if they're dizzy. You've been spinning them around and stuff. Make sure they're stable and good and feeling okay before you get them off the table. They just went through something invasive. It's not invasive needle-wise, but like they're awake for this. It's people, they're embarrassed. It's invasive. It's not comfortable. So consider all those things, right? Now, positionally. So we'll go to our sheet, right? For the comp. It says AP or PA. On the other one, or for example, on the oblique, it's RAO or LPO. There is no or. It's both. Because out in the field, like with an esophagus, no matter how I turn you, the tube is pretty much the same. Here, the contrast is gonna be in different areas depending on the position I put you in. So right now, my patient's in what?
LPO or LAO.
LAO. Where's my contrast?
Where's your what, sorry?
Where's my contrast?
Probably like towards
What
the
stage are we in?
ascending.
So it's on my left side, it's in the flexure, because the flexure is the pivot point between front and back. So your obliques are usually for flexures, your PAs and APs are for your large structures. So right now, if we're in the left, we're in the left flexure, which is also known as the splenic flexure. Yeah, splenic, whatever. So we're in that flexure. If I drop the leg down, so this is going to be my PA, it's going to be at the area of the iliac crest. It's just a KUB, but from the back, right? So you go to the crest, open 14/17, shoot down. It's mostly in the transverse colon and in this rectosigmoid colon at this point, because it sits the most anterior. When I go to flip my patient AP, now what's going to be filled with contrast?
The like ascending and descending.
Ascending and descending. They sit the furthest back, they both fill up, right? I go to turn my patient onto their right side, now my right colic flexure is going to be filled. When I go full lateral, it's going to go to whichever the largest structure is that's down. So if I go on my left side lateral, what am I filling?
Descending.
If I go on my right side lateral, it's just that. It's just fluid dynamics. It's just gravity. That's how the contrast is going to move. You're going to have questions on the quiz midterm final about, in this RAO, where is the contrast? What is best visualized here? What is visualized there? Stuff like that, right? Okay, for the comp, we're going to do the PA. So we'll do the PA for the comp, and we're going to do the PA axial. If you look, the PA axial is 30 to 40 degrees caudad. The AP axial is 30 to 40 degrees cephalic. What was it for the UGI axial? Yeah, basically the exact same, but which direction?
Cephalic.
Cephalic. So the UGI, we're going cephalic for our axial. The large bowel, we're gonna go caudad for our axial. You're gonna come down. So if you were at the crest before, you just shift down to the ACIS. It's basically like when we did the spine work. It's like going down to the spot, right? So you slide down to the ACIS, you angle back through here. The reason people lost a bunch of points last time we did this on the comp, they didn't match their Bucky, and because we're working so low, they were maxing out their Bucky low, and so we had a bunch of them pulling the patient, like their heads like hanging out, like, if you had just done a small amount of prep ahead of time and figured it out, you could have fit it without having to do all this, right? So think about those mechanics. The obliques, both are fair game, the RAO or the LPO. So the way the comp's gonna work if you get large intestine, I'm gonna say, all right, go ahead and show me so we're gonna start in Sims, we're not gonna start flat. So your patient will be in Sims, and then I'll say, all right, you're gonna show me a PA axial, an LPO, and give me a right lateral. Move them around. Obviously it would be more difficult in reality because there's a tube inside of them. We're not doing that for this. We're not taping tubes to the back of people or anything. So you just have to trust that it would be there, right? But you'll do those 3 shots and then we'll roll on, okay? It's the hard one. I think every single time we have a comp, there's always one that's a little bit harder than the others. L-spine was probably the most difficult one of the vertebrae because it had the spot film and like you had to come back a certain amount for things. Shoulder is usually the one that gets people on upper extremity. Same thing here. This is probably the hard one, but you guys already know if you can't do that one, then I can't trust you anymore with any of them. So it's fair game. If you look, there's the decubitus on here. Some facilities require a DQ. We don't have a holder, so we're not going to do it for the comp, but you do need to know it for like quizzes and stuff going forward. Okay? So, questions about any of that? Questions about the comp? We all feel comfortable on those shots? So we're going to do the PA, we're going to do the PA axial, and then you can get any of the obliques or laterals.
So obviously not today because the dummies there, but you'll show us what those shots look like on a person later.
Do it right now, move them down, or do it on that table right there. Yeah. But it's basically that. It's like center to the crest, shoot through and watch it come down. You almost are always going to be 14 by 17 for these because you're trying to fit as much bow. Most people, you'll start portrait. You'll try and go portrait because you want to fit that whole frame in there. You're not going to do it on me. Alan, Ryan, you're probably going to do it crosswise and do uppers and lowers to see everything. So it's totally dependent on what you're, for the comp, we're going to go portrait. Okay? So we're going to go portrait like we did for the, pretty much for the other G.